speaker, and it's my pleasure to introduce the guest speaker of the day. Sir is a senior consultant in general medicine based at Porur, Chennai, with a special interest in lifestyle disorders. He graduated his MBBS from Kilpack Medical College in 1992 and MD General Medicine from Madras Medical College in 1996. He served successively as Assistant Professor, Associate Professor, and Unit Head and Head of the Department of General Medicine at Sri Ramachandra Medical College, Porur, Chennai from 1996 to 2015. He is Adjunct Professor of General Medicine at the Attar University since 2021. He is the Founder President of Indian Medical Association, Porur branch, and life member of various medical associations and societies. A recognized medical practitioner, teacher, researcher, administrator, and organizer over 30 years of experience. He has over 50 research publications in both national and international medical journals. He is recipient of Best Performance Award from the Ministry of Health and Family Welfare and Government of Tamil Nadu in 2018 and Indian Medical Association Tamil Nadu in 2019 and 2018 and 19. We welcome you, sir. The stage is yours. You can start your presentation.
Thank you, madam, for the kind words. I thank the university for providing me an opportunity to organize this webinar, and I'm happy to have two of my friends, Dr. Margaret and Dr. Aruna, as a panelist. And Dr. Aruna was earlier associated with me in SRMC, and she was in the Department of Pediatrics. With the kind words, I will start with the presentation. I am going to do it like a case presentation followed with a discussion, just like how we do most of the clinical meetings. So I will be taking the inputs from Dr. Aruna and Dr. Margaret as and when we require. Is it visible, madam?
No, sir.
Slide.
No, sir, we are not able to see a slide.
I'm able to visualize the slides, ma'am. Slide set approach to.
Mercy. 1 minute. Yes, sir, you can proceed, sir.
Is it visible?
Yes, sir. Oh, perfect.
The full screen is visible or only the part?
Yes, sir. Full screen is visible, sir.
Okay. So today we'll be discussing one of the very important topics in medicine. This is I chose this topic purely because it affects almost all branches. It affects general medicine, pediatrics, pathology, hematology, infectious disease, pharmacology, and all. And it's a very common in general practice also to see this picture, which I am going to discuss. This is an approach to pancytopenia. We'll be discussing about what is pancytopenia, the diagnostic approaches, management modalities, and all later. So I'm going to just discuss with a real life case scenario. So the learning objectives will be to discuss about the definition, the classification, the causes, the clinical features, which we always have to have in mind, because the history and clinical examination plays a major role. Then the diagnostic modalities and management options in pancytopenia. Patient, Mr. B, he is a 60-year-old male in Chennai. He is working as a marketing executive. He came sometime in the month of January with fever, cough, cold, and dry cough for 3 days duration. He also had headache and body ache. His taste and smell were normal. His urine, stools, appetite, and all were within normal. His past medical history: he is a known diabetic for 10 years. He is on glimepiride, metformin, and vildagliptin. This detailed inquiry was also made whether he is taking any of these alternative medicines or complementary and alternative medicines. He denied, and none of this could be made out. For hypertension, he is taking telmisartan for the last 5 years. He was detected to have vitamin D deficiency during his routine diabetic workup, and he was started on weekly supplements for the last 2 months. He has received 2 doses of Covishield in the last during the regular vaccination program. He takes mixed diet. He is a non-smoker, but he chews betel nut occasionally. He's been consuming alcohol on a social basis twice a month for the last 15 years. He's married and he has got 2 children. So there's no other family history of any other ailments. His vitals, his pulse, his height was 163, weight was 69 kgs. His BMI was 25.97, so he was a obese diabetic type 2. And his body surface area was 1.74. Temperature 9.5, pulse was 82, blood pressure was 120/80. The respiratory rate was normal and oxygen saturation was 99. Since he suspected any respiratory illness, so we checked all this. On examination, there was pallor. Other things were anechoic, acyanotic. No bleeding spots were made out. There was no significant lymphadenopathy or pedal edema. His eyes, ear, nose, throat examination was normal. Eyes showed cataract. His ocular fundus was normal. In fact, he had seen for a diabetic workup, for his eye workup during this diabetic workup, cataract surgery. And his systemic examination, CVS, RS, abdomen, and neurological system are all normal. Nothing remarkable could be made out. His investigations showed we did a hemogram because of the fever panel. It showed hemoglobin of 9.5 and a total count of 2,500 and a platelet of 70,000. ESR is 32. Other parameters were normal. So we suspected it could be because of the part of the fever, and we repeated it after 1 week when after the treatment of fever. It turned out to be 8.8 and his total count was 3,780 and his platelet count was 83,000. Then on this, actually there's a mix-up. The 20th value was 9.2. It was a progressive decline. It was 9.5, then 9.2 and 8.8. The total count fluctuated between 2,500, 3,800, 3,250 and 3,780. The platelets were hovering around 70,000, then it went to 89 and 83.
Yes.
So we did a peripheral smear as a part of the thing. It showed erythropoietina. There was microcytic hypochromic RBCs with moderate anisopoikilocytosis, elliptocytosis, echinocytes, few pencil cells, and teardrop cells. The WBC showed leukopenia and no abnormal cells. The platelet also showed thrombocytopenia, and hemoparasites were absent. The pathologist opined it as a pancytopenia. Then his other parameters we did because he was a diabetic. His in December his sugars were 160 and 264. A1C was 9.9. Then in January when he has come for the fever workup, it showed 114, 163, and the HbA1c has dropped to 7.1. His urea, creatinine, electrolytes, calcium, phosphorus, everything was within normal limits. His liver function test showed altered albumin globulin reversal. It showed 3.5 albumin and a globulin of 4.3. I have highlighted only the abnormal ones. Then his viral parameters, BSAG, HCV, and 2 also are negative. They were done on 25th after the fever 1 week, 10 days later because the persisting pancytopenia, we did this viral markers. His urine routine was also normal. Urine analysis, microscopic and macroscopic are normal. He was tested COVID positive, and the day one he had fever and body pain and all. We worked up for fever. We checked because on view of the pandemic situation and short course of fever and a diabetic age. COVID, it showed positive. A week later, it turned out to be negative. His CRP was 2.23, it fell down to 1.2. His LDH was 298, then it dropped to 121, the COVID profile. Ferritin was 27.42, interleukin was less than 3, and D-dimer was 0.52. We repeated only those which were abnormal. They all normalized after a week. So we have the issues in this patient. He's a chronic issues he had is a type 2 diabetes mellitus. Then he's got hypertension and vitamin deficiency. Now revealed, and also he has been having alcoholic liver disease because he's having an albumin globulin reversal, and also he's been taking alcohol for almost 15 years. He has got a COVID-19 infection mild because all the parameters like oxygen saturation, the CRP, D-dimer, everything were within the mild infection, mild category. So he was put on home quarantine. But then the only issue which we had new issue was the pancytopenia. The counts were still persistent even after 1 week. It was persistent. So what could be the possible reasons? We were in a dilemma. So we worked up further whether it could be due to drugs or it could be due to any the viral illness. We had this two possibilities, or it could be due to alcoholic liver disease. Alcoholic liver disease, we all know, produces splenomegaly, hypersplenism. So three possibilities were kept. Drug induced because he has been on some of the drugs for a long time. Then viral illness, but we all know is also associated with pancytopenia. But then when the infection normalizes, the counts improve, and then the alcoholic liver disease where they persist. So we worked up further. So since he had an albumin and globulin reversal, we did a serum electrophoresis pattern. It was done. It showed a M band. So it showed a prominent M band. So the M band was 1.3 in the gamma region, and we suspected a myeloma. So the serum electrophoresis was done in detail. The immunoglobulin was done. I think Dr. Aruna and Margaret Madam will be able to explain further. Then we wanted to do a bone marrow. The bone marrow was done because the hematologist felt we should do a bone marrow to document. So bone marrow was done. The bone marrow was normal. There was no suggestion of granuloma, hemoparasites or thing. The myeloma cells also was less than 5%. We did ECG. Chest X-ray was done initially itself because of the COVID thing. X-ray was normal. Chest X-ray, ECG also was normal. Echo showed concentric LVH, and PFT showed a moderate restrictive airway disease. Ultrasound, I told you, we showed a coarse echo texture, cholelithiasis, the portal cavernoma, and minimal ascites and splenomegaly. So we documented an alcoholic liver disease because other parameters were negative. So HRCT chest was done because of COVID. We wanted as we did to document the ratio severity. It was 0/25, and Cohort score was 6 because he had a COVID positive. The hematologist requested for a whole body PET scan because of the M band, but it showed only cirrhosis liver, minimal ascites, and splenomegaly. An endoscopy done recently showed grade 2 esophageal varices and erythematous gastritis. So the hematologist discussion with the judge to the following conclusion. There is a pancytopenia because the blood picture and the peripheral smear is suggestive of a decrease in all the tri-lineage cells, blood cells. The serum electrophoresis pattern showed an M band, but however, the bone marrow studies were less than 5% of the plasma cells. The patient had normal renal profile and calcium levels. When the corrected calcium levels are within normal limits. The PET scan showed no bone lesions. So the possibility of two things were made: myeloma, gland significance, and hypersplenism with alcoholic cirrhosis because the varices are seen, cirrhosis is seen, ascites is seen. All that the triad of portal hypertension we have made splenomegaly. So it could be a hypersplenism. And a monoclonal gammopathy of unknown significance was made because of the plasma cells were less than 5%. The management patient was managed with oral antidiabetics Already I have told the drugs, glimepiride, vildagliptin, and metformin. For hypertension, he was given sartan. And he was also put on vitamin D and B12 supplements. His vitamin D and B12 as D3 was normal, vitamin B12 was normal. So one of the commonest cause of pancytopenia is megaloblastic anemia levels were normal. And he was already on vitamin B12 supplements, and still the persistent pancytopenia persisted. So we ruled out the other disorders, because diabetic patients with metformin are more prone to B12 deficiencies. Diabetic, especially the intake of vegetable, because B12 is a predominantly, these patients have lesser intake of green vegetables. And the second thing, they also have metformin, which is known to produce B12 deficiency. Even sometimes when people who take non-vegetarian, we are seeing higher incidence of B12 deficiency. The reason being that many of the poultry are treated with antibiotics, and that could induce B12 deficiency in most of these uh, poultry products. So he was put on folic acid, B12, and D3. He was given azithromycin for initial therapy of fever and respiratory infection. He was given ursodeoxycholic acid because of the liver disease, as well as the cholelithiasis as a hepatoprotective agent. The hematologist had given zoledronic acid. He advised every 1 year, and to follow up with CBC, renal function, electrolytes, calcium, and electrophoresis every 6 months. In view of the low platelet, he advised Eltromabag for 2 weeks, which was given before any procedure. The Eltromabag was given here because we were to do the endos improved, and we did. I had given ferropenum for the neutropenia. So this is one of the cases where we have had a multiple causes, and he is being investigated, and he was investigated, and he is being followed up. Now, just I'll give an overview of pancytopenia. Pancytopenia is a decrease in all the three hematological cell lines, namely erythrocytes, leukocytes, and platelets. So when we call it as hemoglobin less than 9, some books give 10, WBC less than 4,000, and platelet less than 1 lakh, we call it as pancytopenia, which we had in our patient. Our patient had 7.5, 8.8, and platelet was WBC less than 3,000, platelet was 70,000. Severe pancytopenia is when the corrected reticulocyte is less than 1%. The absolute reticulocyte is less than 60,000 per microliters. Absolute neutrophil count is less than 500 per cubic liters. And the platelet count less than 20,000. A decrease in all the three hematological lines is called as pancytopenia. Most often we see leukopenia. In that we see neutropenia. Most often we see in the neutropenia we see leukopenia, since neutrophils constitute most of the leukocytes. But the most common finding we see in any pancytopenia will be platelets, because they have a very short half-life. Half-life is almost a week, so most of them will have thrombocytopenia as an initial presentation. The symptoms, as I told you, will be depending on the each cell line. So those with having anemia will have breathlessness, chest pain, palpitation, tiredness. Surprisingly, this patient did not have any of these symptoms, because most of the time he is, for the last 1 year due to COVID and all, he is at home, and he is not moving out, and he doesn't have much of these symptoms. Even the minor symptoms like tired has been attributed. So fever, he had fever, sore throat, he had this fever, cough, cold, and so we suspected in the toughest time due to COVID, we suspected neutropenia. Could be one of the reasons, with poor response to antibiotics. But here the antibiotics, the fever responded. Thrombocytopenia, they have a mucosal bleeding. It could be internal or external bleeding. External bleeding could be either from epistaxis, hemoptysis, or internal, it could be general GI bleed, hematuria, and women menorrhagia. And very severe conditions, the cause of death, cranial bleeding. And all this epistaxis, bruises, purpura, petechial spots we see, especially in dengue fever, we see all this. And as internists, we commonly see fever and thrombocytopenia in dengue. So etiology, to say this pancytopenia is not a It's a syndrome or a common final pathway. It is like fever or like anemia. It's not a common, it's not a one disease, but it is a common pathway of many etiologies. So it could be due to two things. It could be a central disorder where there production defect, could be a peripheral disorder where there could be a increased destruction. As far as Indian studies, most of the studies have shown megaloblastic anemia followed by aplastic anemia. Some of those done in tertiary centers reported those due to cancer chemotherapy, myeloma, and lymphoma and all. But that could be due to a referral bias because most of the megaloblastic anemia and viral or drug-induced anemias which revert back to normal are seen in smaller healthcare facilities. So the central causes could be either due to so it could be cancers. So cancer it could be the acute myeloid leukemia, lymphoid leukemia, lymphoma, myeloma, and metastatic tumors. The granulomatous ones could be the common, could be tuberculosis or fungal like histoplasma or sarcoid. Or it could be fibrosis, extensive fibrosis, which we call as myelofibrosis, or extensive histiocytosis, which we see in Gaucher's and Langerhans. So this could be in central cause due to infiltration. Then central causes, there could be a production defect. Production defect, the cellular production defect could be aplastic anemia, where most often the aplastic anemia or myelodysplastic syndromes. And bone marrow necrosis. Sickle cell anemia is known to produce this vaso-occlusive crisis where they produce bone marrow necrosis like our avascular necrosis, femur and all. Then we have nutritional disorders like vitamin B12, folic acid, copper. Copper is well known. Hypocapric myelopathy is known, which can mimic exactly like B12, which we've seen many times. Protein energy malnutrition. Among the endocrine causes would be due to hypothyroidism. The toxins, alcohol is one of the things, and heavy metals. Very often now they are working in all this mobile factories and electronic factories. Heavy metals are exposure is causing central cause can produce can produce lower production. The peripheral causes are destruction. Increased destruction can be due to disseminated intravascular coagulation and thrombotic microangiopathy. Increased sequestration can be either due to liver disease like cirrhosis and portal hypertension. In our patient, this could be one of the causes because in spite of all the therapies and excluding, this still persists. And it has been documented. Infections, malaria, Kala azar, HIV, tuberculosis can cause. Among the autoimmune rheumatoid arthritis, SLE, the Ivan syndrome. Ivan syndrome is a pancytopenia with ANA positive response well to steroids. Among the neoplastic myelofibrosis, some causes can be due to combined peripheral and central. So a few things which can be combined is paroxysmal nocturnal hemoglobinuria, then hematological malignancies, then autoimmune causes, then HLH syndrome and drugs. Some of the PNH and hematological malignancies we are rarely seen in our general practice. I think our hematology colleagues will be able to explain much. Then coming to aplastic anemia, we have a few things. One is inherited. We have this Fanconi syndrome, which is a chromosomal breakage defect. It is the most common congenital cause of bone marrow failure. Then we have this diskeratosis congenita, this Schwarzman-Diamond syndrome, which is a ribosomal biogenesis disorder. These are very rare and most commonly seen in referral centers or in pediatric practice. I have not honestly saying I have not seen these type of patients. These are the most common, acquired or more common. Among the physical, chemical, and biological causes. Physical causes could be the radiation. Very commonly, radiation is one. It could be either occupational like radiotherapists, radiation technicians, or accidental like happened in all this Hiroshima, Nagasaki, and this Japan. Therapeutic, we give radiation for all lymphomas and head and neck cancers, so that could cause. Chemicals, drugs are there already. There is a huge lot among the anti-cancer drugs and anti-thyroid NSAIDs are there. Sulfonamides and sulfane. That's why I told you in our case, patient was on sulfonylurea, which is almost similar to this group, but we don't see that much pancytopenia, and we have been routinely using in our practice. Among the viruses, even though Paro B19 and all have been seen, dengue tops the list in most of our patients. COVID-19 is often cause aplastic. When we are not able to find out any cause after exclusion, we call it as idiopathic. So these are slides which I am showing a few of them. This is aplastic anemia. So hypercellular marrow is less than 20%. The only thing we need, and it's replaced with a lot of fat cells. These are all the fat cells. This is a marrow. And the marrow cellularity does not correlate with disease severity. We have to keep that in mind. Among the drugs, could be a myelosuppression, chemocytotoxin, as we see in chloramphenicol, are immune mediated. There are a host of drugs that most of these books give. Autoimmune, the pancytopenia has got a bimodal representation. It is seen in children and adults, most commonly in the 4th and 5th decades in adults. There is a male to female predominance. Western countries, autoimmune is neoplastic or common, whereas in Eastern and Asian countries, we see more of nutrition and infections as a common cause. So a thorough history and examination is required in our patient. We require the history of drug intake, medicines. Then we need to do the personal history like diet and alcohol. Women menstrual and obstetric history is detailed. And the family history and occupational history are very important, especially for drug exposure to toxins. Then the general exam, pallor or the icterus, pallor, icterus, edema, clubbing, purpura, and lymphadenopathy we need to do checkup. Then eyes, ocular examination, cardiovascular system, respiratory system to look for any cardiac failure. Among the abdomen, we have to look for hepatosplenomegaly. CNS, one of the most important things we may tend to forget is to look for the posterior column signs, especially the Romberg sign, because B12 deficiency and copper deficiency can produce myelopathy. And bone tenderness is seen in some of the conditions like myeloma and leukemias, lymphomas. So some of the clues on general examination, especially oral, we look for cheilitis, aphthous ulcers, leukoplakia, candidiasis, and skin. These things will help you in all the rarer conditions like hyperpigmentation, diskeratosis, congenita, and Cafale spots. Short stature, radial and thumb defects, skeletal more for the Fanconi group. So this is something which we commonly see whenever I see pancytopenia in Indian setup. Kindly look at this. You get this somewhat like an Addisonian pigmentation. Very often students call them as Addison's disease and then cortisol and all that. A simple CBC will show this. If it shows a CBC and CV more than 110, this could be regular B12 immediately, and you start with B12 injections and folic acid and iron. Most of these patients improve. Instead of doing expensive workup for cortisol levels and then abdomen CT and all that. So one of the commonest causes is not mentioned in many of the books, but one of the commonest causes for Addisonian pigmentation in Indian setup is B12 deficiency. This hyperpigmentation of knuckles. This is Fanconi syndrome, where they have short stature, microcephaly, broad nasal folds, epicanthal folds, Cafale spots, absent radiate thumbs, and dislocated thumbs. This only from a textbook picture because honestly speaking, I have not seen this type of patients. This also keratosis congenita, where they have nail dystrophy and they have this lacy, dirty neck where they have a reticular net-like pattern over the neck creases. This is mucosal leukoplasia, which is called as a triad of keratosis congenita. So this we should know. Pancytopenia with hepatosplenomegaly, pancytopenia, the lymphadenopathy, all. The most common things, infections in India, we have to suspect tuberculosis and virus and all. Then neoplastic causes leukemias and lymphomas. Then autoimmune causes, one of the things which can produce pancytopenia like picture or hepatosplenomegaly, cell leaky, Kuchik's and all can cause this type of picture. Then hemophagocytic lymphocytic histiocytosis, HLH syndrome, and LCH or Langerhans cells histiocytosis. Hemophagocytosis we see, Langerhans cell histiocytosis is seen more in tertiary care, especially in hematology and bone marrow units. The investigations already in the previous case workup we have seen. So it is complete hematological workup and all the biochemical parameters to rule out all the organ involvement. So this is a megaloblastic anemia, hypersegmented neutrophils. We see the megaloblast. So then these are some of the special tests we required if you suspect B12, look for B12 deficiency. Copper and all are very rare. Iron, ferritin, B12 and folic acid. Folic acid we should do red cell folic acid, and B12 you should do serum B12. It's a microbiology bone and required. And HIV and hepatitis C, COVID-19 all for viral etiology. When you suspect bone like this patient, 60 years old, had albumin globulin reversal and non-responsive pancytopenia, we suspected bone marrow biopsy. We did electrophoresis which showed M band and bone marrow biopsy or lymph node biopsy depending on the organ involvement. Immunological RA factor in ENA. Cytometric analysis, we can do the GPA link CD55 and 59 for PNH. And radiology, do the bone X-ray and CT, MRI, PET or ultrasound depending on the requirements. So this is an absolute reticulocyte count. This is reticulocyte count into RBC count. So less than 25,000 we see in aplastic anemia, 25 to 50,000 vitamin B12 and folic and ferritin. Then the bone marrow, there are three types: hypocellular bone marrow, normocellular and hypercellular. Hypocellular is less than 30%. So that includes aplastic anemia, myelodysplastic syndrome, aleukemic leukemia, lymphoma and copper deficiency. The normocellular ones includes MDS, PNH, myelophthisis and myelofibrosis and hairy cell leukemia. The hypercellular is the megaloblastic anemia and hypersplenism, which is a pattern get splenism and B12 deficiency. Myelodysplastic syndromes are usually seen above age of 70, and they have the classical three C3s: cytopenia, cellular marrow, and cytogenetic abnormalities. One of the common things which we need to know is the 5q deletion, which responds very well to lenalidomide, the next generation thalidomide, and acute myeloid leukemia occurs in more than 25% of these patients over follow-up. So these are some of the myelodysplastic syndrome slides. Then management will be supportive. So for anemia, red cell transfusion or erythropoiesis, less than 7 or they have cardiac failure. Empirical parenteral broad spectrum antibiotics and colony stimulating factors may be indicated for neutropenia. Here patient was given faropena. And thrombocytopenia, we give platelet transfusion of eltromapag. Eltromapag was given here. And it also, recent studies have shown that it improves the tricell lineage. And any offending drugs, we need to avoid them, like chloramphenicol or antithyroid drugs or anti-cancer drugs. Then these are the specific things for nutritional acid. For infections, we give antibiotics, antivirals, and antifungals, depending on the etiology. Endocrine corticosteroids, thyroxine, and androgens, depending once again on whatever hormone deficiencies are suspected. Autoimmune disorders very well respond to corticosteroids. Neoplasm, we need to go with the oncology approach of chemotherapy, radiotherapy. And drugs and toxins, we need to avoid the offending agent. Younger age, hematopoietic stem cell transplantation is advised, and older age, anti-thymocytic globulin and cyclosporin combination. This is for aplastic anemia. Prognosis, the following conditions respond very well, reversible, like drugs and toxins, nutritional, infections, neoplasm, most of these things respond very well. Some of them may not respond, and the death is very commonly seen in any of these four things. Could be due to severe cardiac failure or florid sepsis or intracranial hemorrhage in cases of severe thrombocytopenia, and DIC is another cause. Electrolyte disorders can occur because, especially when you treat some of these conditions, there can be hypokalemia, especially when you give transfusion, or there can be citrate overload, or it could be due to tumor lysis syndrome and all. Electrolyte disorders are very common, and they could induce death. Thank you for giving me this opportunity. I now request the panelists to share their comments and
A very nice presentation, sir. You've covered almost everything. Um, just from the outpatient point of view, when you see a patient referred to us with pancytopenia in the general OP, in our OP, we get about 100 to 150 patients a day. The commonest cause of referral is anemia and bicytopenia, pancytopenia. So the first thing to do is just for is lymphadenopathy, as you already put this like pancytopenia with lymphadenopathy and hepatosplenomegaly. Is it a pancytopenia with organomegaly? If it is with no lymphadenopathy, no organomegaly, we think of infections, drugs, megaloblastic anemia. The most important point for the postgraduates is whenever there's a pancytopenia, don't think of aplastic anemia first. The commonest ones are viral infections, as you already documented in your slides. Drugs, especially in elderly patients, native medicines, those who are on homeopathic drugs for joint disease, all of them can come to us with pancytopenia. So infections, drugs, and megaloblastic anemia are the commonest when there is no lymphadenopathy and no hepatosplenomegaly. When there is a lymphadenopathy and hepatosplenomegaly, we think of chronic liver disease with hypersplenism. That is the commonest in the adult OP, and that is what your case also turned out to be. So CLD with hypersplenism whenever there is a organomegaly, and then comes all the malignancies, lymphomas, leukemias, PNH, other hemolytic anemias with an aplastic crisis. Just a few clues with the baseline investigations. When we see the patient with pancytopenia, we always have a look at the MCV. If the MCV is high, the commonest is B12 folic acid deficiency, but bone marrow failure syndromes also can have macrocytosis. So what is important in an adult patient is if you're able to document B12 folic acid assay and document that it is low, then it is fine. If you're not able to document the levels with assay, it is better to treat the patient along with corroborative signs like a hypersegmented neutrophil and macrovalocytes, whereas in aplastic MDS, what you see is a round macrocyte. So treat the patient with B12 folic acid, always follow up and see if the patient is improved. If not, always keep in mind aplastic and MDS. That is what we usually tell any macrocytic pancytopenia. Follow up the patient in 3 months and see if they have responded to the hematinics. If not, we'll have to think of aplastic and myelodysplastic syndrome. Then, as you said, sir, pancytopenia with a hypocellular. Next investigation will be a bone marrow aspiration. So, pancytopenia with a hypocellular bone marrow. Just two important causes. One is aplastic anemia. The other is hypocellular MDS. What is important for postgraduates is MDS is always a intensely hypercellular marrow in most patients. Only in about 3 to 5% in the Western literature, and in our patients, about 10 to 15% of our patients do have a hypocellular marrow, myelodysplastic syndrome with a hypocellular marrow. So the two differential diagnoses would be aplastic and myelodysplastic syndrome. Hypercellular marrow will be the chronic liver disease, megaloblastic, immune, malignancies, other infections, etc. So, coming to this patient, regarding MGUS, I thought I will say a few words. Monoclonal gammopathy of undetermined significance. The quantity was much less than what you need for a myeloma. Generally, for a myeloma, IgG should be more than 3 grams to think of myeloma, whereas in this patient, it was around 1 or 1.5. So it is most probably MGUS, and that has been confirmed by doing a bone marrow aspiration. In this context, there are two new things. One is ICUS, idiopathic cytopenia of undetermined significance. These have been newly added. MGUS was there for myeloma with a monoclonal bank with no myeloma. Now in MDS, we have this ICUS and CCUS, that is idiopathic cytopenia of undetermined significance, which is not clonal. You just have some mild cytopenia. It is not clonal. There are no dysplastic changes. There are less than 5% blasts in the marrow. These patients have to be just followed up. The other is clonal cytopenia of undetermined significance. It could be any cell lineage. Clonal cytopenia is a malignant clone is there. So that is something we should bear in mind. Since we have an MGUS, we also have to know ICUS and CCUS, which is now the myelodysplastic syndrome. Coming to the investigations that you do in a bone marrow aspiration when there is a peripheral pancytopenia, one is morphology. The other thing is we also have to do a karyotyping flow cytometry to quantitate the number of CD34 cells, and a bone marrow biopsy to document dysplastic changes and also fibrosis. Always, bone marrow biopsy is a must to make a diagnosis of aplastic anemia and myelofibrosis. So, cellularity and fibrosis are best diagnosed with a biopsy rather than a bone marrow aspirate. The bone marrow aspirate, when we collect the sample, we have to do a morphology. We'll have to do karyotyping, because if there are karyotypic abnormalities, that favors a myelodysplastic syndrome rather than an aplastic anemia. Confirmation is by flow cytometry. Also, we can send a sample for PNH clone from the marrow aspirate or from the peripheral blood CD55 and 59 to rule out presence of associated PNH clone that can be there in aplastic as well as MDS. But to make a diagnosis of aplastic anemia, there should be no dysplasia, there should be no blast, and there should be no fibrosis in the marrow. Those are the three important negatives. Not only a hypocellular marrow of less than 30%, there should also be no blast in the marrow or less than 10%, there should be no dysplastic changes, and there should be no fibrosis. If these three are there, then it is more in favor of a myelodysplastic syndrome. I just had 2 slides to just approach to aplastic. Is the screen visible? Is it visible?
No, no. No, ma'am. Margaret, ma'am, no.
Not visible. Eh? Not visible. Screen not visible.
No, no, ma'am.
So I will just
Visible now.
visible. Okay. So this is what I said. If you have a pancytopenia and peripheral blood, do a bone marrow for diagnosis. If you have blast, dysplasia, or fibrosis, you think of myelodysplastic syndrome and acute leukemia. And karyotyping is also important from the marrow, because if there are abnormalities, you think of MDS. And you're suspecting a congenital aplastic. In fact, even in a young adult without any of the peripheral signs of Fanconi's, we have to do a stress karyotyping with either diethoxybutane or mitomycin C to rule out a Fanconi's anemia. So only if that is negative, we make a diagnosis of acquired aplastic. So aplastic we classify as severe and non-severe. So severe is when the ANC is less than 500, platelet count less than 20,000. Then based on the age, we decide on the treatment. So if it is a young patient less than 45, with the HLA max sibling donor, we plan a transplant. If there is no donor, or if it's an older patient, then we put the patient on horse ATG plus cyclosporin and L-Trombobag. So that is regarding the management. So I think the inherited aplastics, Dr. Aruna can.
Yes, ma'am. Actually, sir, it was extremely, you put a lot of labor in those slides here. Those slides have really been prepared well. And it was a very comprehensive presentation. And it is very interesting to see that the patient also had a positive, like a high M band. But otherwise, most of the time we would have stopped with the workup of identifying cirrhosis and like labeling him as hypersplenism. But you have gone a step ahead, and a workup has shown a leading point, but I think that will anyway require a further follow-up. So as Madam has told, the common causes in adults and children, pancytopenia, as Ma'am has told, whether we end up having organomegaly or lymphadenopathy based on this, and also a well child and a sick child. So sick children, we work up more towards HLH. Sometimes LCH also presents as sickness and skin rash and cytopenias. Whereas, malignancies can either present as a sick child, or sometimes they can even walk to the OPD. whereas these storage disorders, nutritional anemias, they are going to, and drug-induced cytopenias may present as like they can just, they will appear well-looking. So most of the time when we work up pancytopenia in children, we have ended up in identifying like B12 deficiency, which is often nutritional. So when we do a CBC for the mother, she herself will be having megaloblastic anemia, and the family will be vegan. So that is most often the scenario for when we work up for a pancytopenia. So sometimes we have seen like inborn errors of metabolism affecting the B12. So B12 metabolism defects, including absorption defects, as seen in Emerson-Grasbeck syndrome. For some reason, it is slightly more common in our population than what is, because I have not seen such cases in North India, but it seems to be more common in our population because of consanguinity. So these children have proteinuria. So when a child less than 1 year comes with megaloblastic anemia and has, we always do a urine routine to identify proteinuria. So similarly, when an adolescent walks to us with megaloblastic anemia, we have identified even like a pernicious anemia in a Jain family. So he is a vegan, so he never ate meat, but he also had hypothyroidism. So because of hypothyroidism, when we worked up, we identified him to have pernicious anemia, presenting as, initially we thought as nutritional, but it was actually pernicious anemia. So the other unusual causes that are seen are sometimes children when they have insulin-dependent diabetes and they present with pancytopenia. We have identified thiamine response to megaloblastic anemia. Again, it is very, very occasional because we are working in a medical college setup and being a referral center, we are seeing such cases, but it is this thiamine response to megaloblastic anemia responds to oral thiamine, and they have very less insulin requirements, these children. Though they have diabetes, their insulin requirements are very minimal. The other cases which are of interest where there are adults, there's an adult who presented with pancytopenia, and he was on, as Madam told, as drugs, methotrexate and infliximab for rheumatoid arthritis. So when he had persistent cytopenia despite withdrawal of methotrexate. So this patient, after 6 to 8 weeks, he underwent a bone marrow, and bone marrow actually revealed granulomas and he had tuberculosis. So these are other unusual presentations of infections as pancytopenia. There is one, there's one more patient who was interesting, was a 60-year-old. He had a metastatic osteosarcoma, but he persistently had pancytopenia. Initially, the metastasis possibly in the marrow was considered to be the cause. So a marrow was done, and the marrow revealed Paget's disease. So these are very unusual causes of pancytopenia, whereas as most of the time it is often B12 deficiency. But sometimes, as you told in the beginning, pancytopenia puzzles us more than any other hematological finding. About inherited bone marrow failure syndromes, again because of consanguinity and breeding in the same caste, we do see a lot of Fanconi anemia in our routine pediatric practice, in ICH. So maybe we have around 30 children with Fanconi anemia on follow-up. So these patients, they initially, when they present to the like a physician, they may have isolated thrombocytopenia, they may have isolated macrocytosis in the initial CBCs, and sometimes they are diagnosed to have recurrent dengue fever because they present they have thrombocytopenia forever, and whenever they have a fever and they are diagnosed to have dengue. So again, this is various presentations of Fanconi. Dyskeratosis congenita is we see up to 12 to 14 years in ICH. We have seen 2 children with dyskeratosis congenita. Otherwise, Fanconi's anemia is the most common presentation of inherited bone marrow failure syndrome. And as Madam told, they can present as late as up to 40 years. So even an adult in workup for aplastic anemia, they should have a Fanconi anemia ruled out. And these patients characteristically have growth failure. So presence of growth failure should always trigger us to look into the possibility of Fanconi presenting as aplastic anemia. Thank you.
Thank you so much, sir. It was really a wonderful discussion by the panelists also. It was like reliving our intern days. We've really learned a lot about pancytopenia today. We open the forum to the other participants in case there are any doubts or any other things to add on. You can please do it, because I think the three of them have really covered extensively. But in case you have anything more to add on, kindly do it now.
So the immune-mediated disorders also present as pancytopenia, as sir mentioned, like autoimmune diseases, they can present as close as like a severe aplastic. So the, whenever a patient is diagnosed with aplastic, we always do a ANA, a B12 level, just to rule out these two causes which are treatable or treated in a totally different way. So those conditions are recognized as presenting as severe aplastic anemia. So it is these two are done. The other is immune deficiencies. In children, immunodeficiency can present with pancytopenia, hepatosplenomegaly, so including chronic granulomatous disease, conditions like severe combined immunodeficiency. All these can, retroviral infections can present as cytopenia along with organomegaly.
So what would you be suggesting us to start off when you see a pancytopenia in an adult, sir? What will be the, the chronology of investigation, sir? What will be the first two which you would like to tell? Either sir or Margaret ma'am?
First would be a complete blood count.
Yeah.
Peripheral smear examination, reticulocyte count. Generally, the first line investigation for a anemia or bicytopenia, pancytopenia will be a CBC, reticulocyte count, and a good peripheral smear examination. CBC including the RBC indices. Then based on that, we go to the second line, which is bone marrow aspiration biopsy. Before that, clinically, depending as I said earlier, if there is a pancytopenia with no nodes or organomegaly, we'll be thinking of infections. So if the patient is presented with an acute febrile illness, fever profile, B12 folic acid assay, ANA, and ultrasound abdomen or portal Doppler to rule out chronic liver disease, because these are the common causes of pancytopenia. And then a bone marrow aspiration and biopsy with all the other investigations from the bone marrow, as I already suggested, to confirm the diagnosis of aplastic or MDS or a malignancy. So first line would be CBC, peripheral smear, and reticulocyte count.
Okay, ma'am. Thank you. Anyone else who wants to add in? Okay, I think if there isn't any, then we'll call it a day. Thank you so much, Dr. Sridhar and the panelists, Dr. Margaret and Dr. Aruna. Then Dr. Sudhakar, I'm sorry, Dr. Sudhakar, Margaret and Dr. Aruna, thanks a lot. We look forward to seeing the next, all of you in the next meeting, probably in the first week of next month, March. Thank you so much.
Thank you, ma'am.
Thank you. Thank you.